We know well the benefits, the clinical benefits of SGLT2 inhibitors. However, the mechanisms underlying these clinical benefits are not very clear. We know about the congestive actions, and also the metabolic effects and anti-inflammatory effects, but in particular the effect on heart remodeling, adverse heart remodeling, is not well known, with scarce of results and also different results. So now we look at the heart in order to know in which way the initiation of dapagliflozin, in this case, is associated with an improvement in reverse of remodeling in heart failure patients. Now, SGLT2 inhibitors currently are in the clinical practice, so the design of this study was open label and single arm. But one of the strengths in the design is that we recruited a chronic heart failure population with long-standing heart failure, and also a very well optimized treatment in a clinical stable condition. The high rates of guideline-directed medical therapies was really assuring about this optimized treatment, except because patients were not receiving SGLT2 inhibitors, of course. So with this inclusion criteria, we recruited 162 patients. We intended to have, using a parallel inclusion, to have a similar proportion of patients with reduced ejection fraction and preserved ejection fraction. So after the procedures of the study were directed to study remodeling, atrial remodeling, and also left ventricular remodeling. And we included echocardiography and also blood sampling at baseline, just before the initiation of dapagliflozin, the same day, or 24 hours before. And we repeated the procedures at 30 days and 6 months. So another strength of the study is that the interpretation of echo parameters was blinded to patient and also to time. So it was performed in an echo core lab at the end of the study. So this is the way to assure that the primary endpoint changed. The primary endpoint was change in left atrium, the ability to reverse left atrium remodeling in terms of left atrial maximal volume, was reliable for us. The key findings is the primary endpoint was the change in left atrial maximal volume indexed at the change from baseline to 6 months. It was positive. We observed a reduction of left atrial volume index. The reduction was mainly explained because the reduction of the reservoir volume. No other change were observed in terms of left atrial remodeling. But it is true that we observed advanced left atrial disease in this population. So probably this explained why we didn't observe an improvement in other parameters like strain, reservoir conduction and contraction parameters. In addition, we also observed an improvement in all parameters of left ventricular remodeling, left ventricular mass, diameters, volumes, and also a mild increase in left ventricular ejection fraction and global longitudinal strain. And it was also associated with a reduction of NT-proBNP levels and an improvement in quality of life. So the main finding is that global adverse remodeling was reversed by the administration of dapagliflozin in this chronic and stable population. So I think in clinical practice, for the clinician, this study reassures about the benefit of dapagliflozin in our patients. When we need to avoid the inertia of not changing treatment, because we are talking about a stable population, chronic population, and the inertia usually is a problem to change treatment. So even in this population, stable, chronic, the introduction of dapagliflozin was associated with an improvement in clinical endpoints, but especially in heart health, because remodeling, global remodeling, atrium remodeling, atrial remodeling, left ventricular remodeling, global remodeling is a very good indicator of global health of the heart. It is preventing or protecting the heart from new events, from the progression of the disease in the mid and long-term follow-up. In the recent EC guidelines, I think one of the news in these guidelines was to give us a new concept, no? It's left atrial disease. I think we in the next years we have to keep in mind the left atrium, because prior trials have not addressed this question. Sacubitril/valsartan has really good data from the Prof HF, from Evaluate trial, and also from Paramount in preserved ejection fraction about the ability to reduce left atrial volume and to improve, to reverse left atrial remodeling. But we have no data about the other pillars of our treatment. So, but I think it's important to demonstrate that protecting left atrium, we are also protecting left ventricle and global heart function. Indeed, we are preventing the progression of the disease. There are studies about demonstrating that very well that there is association between left atrial volume and the incidence of atrial fibrillation. In our study, almost half of patients were in atrial fibrillation. So we have not looked at the incidence of new onset atrial fibrillation. But I think atrial fibrillation is one element in one other part of the story of left atrium. So we need to protect the remodeling, the adverse remodeling, and this is the way to give an additional value to our treatments. In this way, to prevent atrial fibrillation is the one endpoint in the follow-up. But before atrial fibrillation, we have left atrial disease. So we need to keep in mind to treat early to improve left atrium health and prevent atrial fibrillation in the long-term follow-up.